Hey, good afternoon, everyone, and welcome to the R Street Institute's webinar on unpacking the national vaping statistics. My name is Jeff Smith. I'm a senior fellow in the Integrative Harm Reduction Group, where we focus on introducing and supporting policies that allow for better health choices and health options for individuals that engage in activities that might carry risk along with them. We focus on everything from opioids to sexual health and other drugs, as well as obviously the topic for today's conversation, tobacco harm reduction. I'm very excited about our panel today. We have three wonderful scholars that have been working on this problem for many years. And our goal for today is to focus on really trying to understand the vaping or electronic nicotine delivery system spaces in terms of how consumers are using the products and what we can learn from those patterns of use to continue to move tobacco harm reduction forward. I will be amiss to not point out that today is Halloween, and I will go ahead and tell all my friends and colleagues joining us today that if you're expecting me to wear a costume in celebration or participation, you obviously don't know me well enough. I would never wear a costume for anything like this. But if there's ghouls and goblins knocking at your door at this hour, feel free to throw them some candy and hurry back. This will be recorded and shared out to all participants. So feel free to take a break for an M&M or a Reese's Pieces or whatever your candy of choice is. As we go through the afternoon, if you have any questions in the Zoom interface, there will be a link for you to post them. And as the panelists finish their short presentations, we'll come back together and we'll have a conversation around what we learned, and any of the questions that you might provide to us, we'll ask and get their insights on those topics as well. So to kick things off today, I'm very excited to have Annie Kleikamp. She is an assistant professor at the University of Maryland School of Medicine in the Division of Addiction Research and Treatment. She's also the Director of Research and Evaluation at the Maryland Addiction Consultation Service. She has worked in this space since 2014. Lots of publications, including reviews, meta-analysis, popular press articles, and obviously with a focus on harm reduction in the tobacco and opioid space. Her section of our session today is titled "The Benefits and Risks of E-Cigarettes Across the Lifespan. What about older adults?" And so I'll go ahead and hand this over to you, Annie.
Great. Hi, everybody. Hello from Baltimore. Let me go ahead and share my screen. I got a few slides. All right. There we go. Really quick for disclosures. I do work, I'm fully employed as a faculty member here at Maryland. I also have a consulting firm that I developed in the last few years. In the past 33 years, I've worked with different organizations. Previously was at Penny Associates, but that's been 5 years. And I don't have any funding from pharmaceutical or nicotine tobacco industries. So I think my part of the conversation, I just want to quickly emphasize a group of people in the US and throughout the world that often isn't included in research on nicotine and tobacco, either purposefully excluded because of research having a cutoff of 65 for participants, or because from my perspective, I think there's been a large focus on prevention and youth, which is understandable, but I'll hopefully make the argument that older adults are not a negligible part of this population, and most of them smoke and don't vape, at least in the US. So smoking is age-related disease. This is not something that's newly understood, but often not framed that way. We know that mean lung cancer diagnosis, age 70, COPD, 66. Lots of people live with smoking-related disease, although it does, as I point out here, one study that's sort of dated now, 12 times greater healthcare costs for adults 65 and over who smoke compared to middle-aged counterparts who smoke. So that's not even including people who don't smoke. So basically, older adults are carrying a lot of that burden, either financially or through their health and suffering. So a paper I recently published earlier this year in American Journal of Public Health highlighted what is often not stated. So we talk a lot about steep reductions in smoking prevalence in the US. I have, age groups, these are adults. The purple line are older adults, so 65 and over. So it's been about 20 years that smoking prevalence has remained between, say, 8 and 10%. For this age group, its smoking prevalence for older Black males in the US is much higher, as well as Native American, Alaska Native. But in general, we're just not seeing those drops. And we know, a few things why that might be the case. But one thing I did do is extrapolate the latest data and showed how, because we've had that steep reduction in smoking among adults 18 to 24, with maybe many of them hopefully switching to safer products or quitting altogether, but we haven't had, that reduction for older adults. Meanwhile, the older adult population is growing. So we've worked really hard for a lot of us to live longer. We've worked, no matter if you smoke or do other dangerous things, you're going to live longer according to prevalence estimates. So because of that, if you extrapolate to census data, I estimate there's 3 million more adults 65 and over in the US that smoke compared to those 18 to 24. And so what do we know about older adults? Well, not a lot. I'm currently in the middle. I submitted it to SRNT, cataloging all SRNT abstracts from the last 5 years in terms of what age group they focus on. The abstract I submitted, which was preliminary from our scoring, was older adults were maybe 5% of the studies presented. Young adults, adolescents were a large majority, maybe 80% or over. And so we don't know a lot, but the little bit we're collecting as research grows, we know that older adults tend to be heavier daily smokers, have, of course, smoked for a longer duration, so often 40 to 50 years. We know that quit rates, at least in the US, have stalled. There's some data to suggest that in Europe and the UK since at least 2005. So what we're seeing is that older adults, smoking cessation rates are not going up. We know that traditional tobacco control interventions don't appear to be as effective for adults 65 and over. There was a paper in Addiction that looked at this that I'm happy to share after the talk. Older adults are the least likely to use e-cigarettes in the US, so less than 1% of adults 65 and over currently use e-cigarettes. And the bigger piece that I think is not discussed a lot, if you start looking across, and my next slide goes into this, across the misconceptions of nicotine's harms, e-cigarette harms, literature, you'll see that older adults are often the least accurate on the harms of nicotine versus smoking. So here I have, and I've been liberal in my definition of older, no offense to anyone. The problem is a lot of our surveys, including PATH, really don't gather data from older adults, and they definitely don't oversample like they do for younger cohorts. So we often have to make our age range. You'll see that in a lot of studies, 55 and over. But these studies are just basically showing the gray bar are the older adults, the blue, the younger. Nicotine is the primary disease agent in tobacco. You see here with people don't know how harmful e-cigarettes are compared to cigarettes, more likely for older adults. E-cigarettes are more harmful, about the same as cigarettes. And then a rapid presentation I gave at SRNT sort of delved into this even more so. So we looked at PATH data. We found that 72% of the older adults, which we had to define as 55 and over, due to limitations of the survey, rated e-cigs as equally or more harmful than cigarettes. So that's really, as far as I understand, matching the general population. A lot of people think that, but we found this was even more likely if you were low SES and non-white older adults, which is suggesting, this intersectionality with race and health disparities. And then we also found that participants planning to quit or switch or have e-cigarette use intentions had greater misperceptions. And so that I don't think is surprising to people, but let me just stop this. I think it highlights that the patterns I think we are seeing with misconceptions are present among older adults, and I think they're even more common among others. For example, thinking that, the harms of smoking are overrated. The benefits of stopping are not as robust, and that's often older adults report that. So I think it's a population that harm reduction products like e-cigarettes could really be beneficial for. Unfortunately, I do think the way policies have been focused and a lot of the advocacy groups towards younger people have really made this difficult. So a lot of my work is now looking at how could we correct misconceptions in older adults and sort of increase this use of lower risk products like e-cigarettes.
Excellent. Thank you, Annie. I have a couple of questions that I'm going to hold as being at least as a good moderator. I'll try to keep my questions to the end, like everybody else has to. But excellent work. Our next panelist, who is going to give some insight around methodology in terms of specifically how data in the vaping space may be used inappropriately or designed inappropriately, or all the above. Brad Rodu is a professor of medicine at the University of Louisville. He also holds an endowed chair in tobacco harm reduction research and is a member of the James Graham Brown Cancer Center at the University of Louisville. I've been reading his work for decades. He is a tremendous scholar and scientist, and very excited to have him with us here today. I could go into depth in his CV, but we need another 3 or 4 hours just to do that. And so if you're interested in his background, we can always share that with you further. But without further ado, I'm going to hand the floor over to Brad.
Thanks very much, Jeff, and thanks to the R Street for the opportunity to make this presentation. My slides are showing, I gather. They're in good shape. My research is supported by unrestricted grants from tobacco manufacturers to the University of Louisville and from the Kentucky Research Challenge Trust Fund. And what I'm going to do today in a very brief presentation is talk about bad science and how that's the real epidemic that's preventing smokers from switching to vaping products. Now, I believe it starts with the National Institutes of Health, because their mission, the federal mission here, is to create a world free of tobacco use. That's, in essence, a fancy phrase for prohibition. And you can see how much influence the NIH has. This is from 2 very quick NIH reporter searches in 20 and 22. You can see that they funded somewhere around 1,500 projects with tobacco to 300 organizations all over the country and all over the world. You're talking about money in the range of $750 to $800 million being distributed all over the place. And the result of that, as of October 30th, yesterday, are 8,600 publications on e-cigarettes and ends, and 95% of those since 2015. So we have a lot of information pouring out of American institutions about e-cigarettes. And let me tell you, I don't think a lot of it's positive. Almost all of it is negative because of this federal mission. Now, that even includes the FDA budget itself. I obtained the fiscal year 2022 budget. It is $775 million. And a lot of that goes toward research. And so the FDA is transferring a lot of money over to NIH to fund these tobacco activities. You can see the other things, public education and compliance. Not going to talk about those today. Now, ever since I started in this field back in 1994, I've been trying to keep the scientific community on track with respect to the quality of their publications. Our recent effort has focused on vaping research because it's clear that it has some deficiencies. You can see that we've published 7, or at least we've challenged 7 different studies in the past few years, one of which has been retracted. That's number 3 there. Number 4 was completely revised without any acknowledgement of our efforts, as was number 6. But we continue to try to hold these researchers accountable. Now, one of the ways we do this is by publishing our own research. As you probably know, there have been a lot of diseases linked to vaping. We're talking about serious diseases like heart attack or MI, stroke, respiratory diseases. Those seem to be real popular. Hypertension and prediabetes as well. All of these reports on the right side of your screen have come from us scientists looking at cross-sectional studies. That is, survey data sets from the federal government in which they're trying to make a connection between vaping and these various diseases. If you look at that journal list, it's a pretty prominent journal list that where these papers are being published. Now, we published a recent paper. We made the statement that all of these previous studies contain no information about when the person was diagnosed with the disease, when they started smoking, and when they started vaping. And without making those key connections, you just can't say that vaping caused any of these diseases. So what we used was the population assessment of tobacco and health. That's the NIH FDA data set. And we can explore these temporal relationships because PATH contains information about when folks started to smoke, started to vape, and were diagnosed with their diseases. Now, here's some results from our study. And the panel looks really complicated, but it's actually very simple. On the left is where are the age groups at which people started smoking. And then at the top are the age groups at which people were diagnosed with COPD, emphysema, MI, and stroke. Now, if you can notice those gray areas, those are areas in which it's very clear that people started smoking before they were diagnosed with the disease. And of course, that's the case with cigarette smoking. 90+% of all those diseases were caused by cigarette smoking, which preceded the diagnosis. In contrast, there are very few people who had their disease diagnosed before they were vaping. The gray bars contain very few numbers. The white bars contain a lot, or the white areas contain a lot more in the lower left. And you will notice, however, the diagonal. That contains a lot of numbers. That's where start of vaping occurred about the same age group as the diagnosis. Now, we also looked at these in this graph, and we went back to age at first using an e-cigarette versus age at first starting to smoke cigarettes. And of course, almost everybody started smoking first. So we were able to show that cross-sectional studies, unless you have those ages, are completely unreliable with respect to whether or not vaping was even involved in those diseases. Now, my take homes, well, they're fairly straightforward. The U.S. federal mission for a tobacco-free society lavishly funds institutions across the U.S., and some of the research that's coming from them is not very good. I don't see very good pre or post publication review of the science. It gets passed into publication very quickly. And if we don't do anything about this, it's going to deter smokers from switching and support harsh and unfair regulation from the FDA. Now, you might say, why am I concerned about this? Well, in 1981, the New England Journal of Medicine published a famous or infamous study of smokeless tobacco and mouth cancer. And I guarantee you it was very, very bad research. But because of that paper, everyone in the US, including most health professionals, believe that dip and chew products are death sentences for mouth cancer. I don't want that to be e-cigarettes and vaping's course. And so I'm very, very much opposed to the type of research that's coming out right now about vaping. Thank you very much.
Yeah, thanks, Brad. I again, trying to hold my tongue. I'm going to continue to do a good job. I have one more speaker to get through, but definitely lots of points of clarity in your presentations. Thanks again, Brad. Our final, last but not least, panelist is Dr. Cheryl Olson. And Cheryl has been in the harm reduction space for over almost 2 decades now as well. She spent 15 years at Mass General, Harvard Medical School, where she co-directed the Center for Mental Health and Media. She's authored multiple works on the intersection between mental health and tobacco and other product use, and consuming other consumer type behaviors beyond the drug space. She now is a consultant on her own and also working with McKinney Regulatory Science Advisors. So again, her topic is going to be really around how we can make a difference with tobacco harm reduction through providing influencers in that space, public health experts, physicians, et cetera, the right information at the right time. So Cheryl?
Thanks so much, Jeff. So I'm going slide free for Halloween, but I'll give a handout version of what I say with citations to our street. So let me start with some context. Back in 1965, 42% of US adults were regularly inhaling tobacco, and college graduates at that time were about as likely to indulge as less educated folks, and that's far from the case today. The CDC says that nearly 30 million of our fellow Americans are still smoking. That's about 12 in every 100 adults. And why do you know so few of them? It's because smoking is increasingly concentrated in what my public health colleagues call vulnerable populations. Among people with graduate degrees, a lot of us today, 3 in 100 smoke. Among people who left high school and got a GED, that's 31 in 100, says the CDC. And same among people with mental health issues. Among people in severe psychological distress, 28 in 100 are smoking. That's almost 3 times the 11% of people who feel emotionally okay. So who else is smoking? Folks who are low income, chronically ill, incarcerated, who are uninsured on Medicaid. The more of these disadvantages people have, the more likely they are to smoke. So we need to focus first on these vulnerable groups, on the people who need the most help. People who could fairly easily quit smoking, they've already quit. Simply put, the easy wins against smoking are over, but we've got to keep trying. Cigarettes keep on killing almost 500,000 of our fellow Americans alone every year, not to mention worldwide. So why are we talking about vaping today? Because research shows that the current quit smoking medications can't solve our smoking problem. A 2021 analysis in the Journal of Preventive Medicine showed that the prescription patches and pills, they work in ideal clinical trial conditions, but they barely budge the needle in the real world. And it's easy but useless to keep blaming smokers for not liking and using these kind of products. We may want smokers to take their medicine, but to truly save lives, reduced risk products have to appeal to people who smoke. Abstinence from tobacco use is the ideal. The next best result for people who can't or don't want to quit nicotine is moving them down the continuum of risk, away from combusted tobacco to a less harmful product. And qualitative research with people who've switched successfully from smoking to vaping, they show that vaping copies what some call the biopsychosocial experience of smoking. Using an e-cigarette can feel and look like smoking. So can vaping help people who've repeatedly failed to quit smoking with the usual medication treatments? Yeah. For example, one UK randomized trial found that vaping worked 6 times as well as NRT for people like that. After 6 months, when people who smoke could choose a flavor or strength of e-cigarette that they liked, they were randomized to e-cigs, 19% had quit smoking compared to 3% who were randomized to a choice of half a dozen NRT products. We need more research, though, on how vaping can help vulnerable populations transition away from smoking. This includes the research Annie described on older people who've smoked for decades. But a good example of this link between compounded disadvantages and smoking is found in jails and prisons. People in custody smoke at roughly 4 times the rate of people on the outside, and most of them have a history of other substance abuse as well. A WHO report said that tobacco use is completely entangled in prison life, where it helps people cope with boredom, deprivation, or stress, relieves anxiety and tension, and functions as a source of pleasure or monetary value in an environment without currency. As part of a PMTA submission to the Food and Drug Administration, I studied perceptions and use of an e-cigarette that was designed for use in prisons and jails, specialty product where you can't smuggle things or stab people, so on, called e-cig for inmate. Researching the plight of people held in supposedly smoke-free prisons was eye-opening to me. A lot of contraband tobacco and some very dangerous versions. One recently incarcerated person that our team interviewed described watching guards spit out chewing tobacco that was then quickly scraped up by prisoners to rechew or to dry out and save for smoking later. That's how desperate some of these guys are, this man said. Tobacco in jail is basically air. So we surveyed people recently released from jail or prison. And one issue that we were looking at was, will people who used cigarettes regularly before incarceration be willing to vape instead of using contraband tobacco? We found that when people had a chance to buy this e-cigarette in prison, 95% of them tried it, bought it once, and 99% kept on buying it and kept on vaping it. My public health colleagues often think of e-cigarettes exclusively in terms of health risk to teenagers. I found that talking about vaping in the context of the traumas and needs of people in custody shook up their preconceptions and made them more receptive to good data about how and why vaping could save lives. We need to find additional customized ways to meet the needs of these vulnerable groups. And we need to focus on people who can help these vulnerable groups switch away from smoking. Let me talk a little bit about physicians. Surveys suggest that patients typically hear about e-cigarettes from the media, family or friends, or vape shops, and few from their doctor's offices. But surveys say that most patients who would use e-cigarettes would like their primary care provider to talk with them about vaping. And physicians, unfortunately, share that widespread misperception that nicotine by itself is dangerous to health. In recent surveys by Rutgers University, 4 of 5 doctors strongly and wrongly agreed that nicotine causes cancer, heart disease, COPD. Didn't matter what their specialty was. This miscasting of nicotine as the primary health villain is concerning and dangerous. It may make doctors hesitate to recommend even nicotine replacement therapies, as well as reduced risk nicotine options like vaping to smokers who seem unable to quit. Reviews of research show that doctors are aware of vaping, but They are far from expert in its health effects and its use for smoking cessation. Most of what they know, like everybody else, came from popular media stories, advertising, internet, or things that patients told them. 5 years ago, in a nationwide survey of physicians, over 2/3 said that a patient had asked them about e-cigarettes, and 1 in 5 at that time said they'd recommended them to a patient who smoked. But we need more up-to-date information about what doctors are doing and what they're willing to do. And we need to do more to educate health professionals, not just doctors, but broader, about vaping and other reduced risk alternatives. The UK government has done a great job providing readable summaries of research that doctors and patients can use. But the sources we usually look to in the US, the CDC, the FDA, the large nonprofit health entities, as we've been discussing already, they've been pretty much laser focused on youth vaping prevention. This year, I wrote several articles about tobacco harm reduction for the Physicians Research Institute. They work with state medical societies on a variety of issues. And it was amazingly difficult to find basic research-based information that could help doctors feel comfortable recommending reduced risk nicotine products. Even finding the simplest things like descriptions and pictures of the types of e-cigarettes and smokeless products that are currently sold in the US. Products that doctors could recommend to patients who have failed with or don't want medication options. We need to find ways to get all of this high quality persuasive research that's out there that we'll be discussing more today, distilled into easy to access formats that physicians can use to educate themselves and to educate patients, and distributed through channels that doctors perceive as trustworthy. Doctors need to know that the FDA recommends educating adults who smoke about the relative risks of tobacco products, that harm reduction continuum. We need to tell them, encourage your patients to try quitting with medication options, but if that fails, alternatives such as e-cigarettes may save their lives. In conclusion, let's focus on the people who need the most help and focus on people who can help these vulnerable groups switch away from smoking.
Excellent. Thank you very much, Cheryl. So again, as a reminder, on your Zoom interface, you should have a button for Q&A. And if you have any questions for any of our panelists, feel free to send those on and I will curate them accordingly. If you don't have any questions, I'll be asking all the questions, and it might get boring from my perspective. I'd much rather hear from all the folks that are online with any of their insightful questions they may want to share with us today. But I will get things rolling as questions start coming in. Annie, I feel very close to this particular segment of the population. I am on the cusp of that 55 age space. And so if you had the ability, again, from my perspective, I really think there's not a single solution to solving any complex problems such as smoking, and educating consumers as to what their options are and which ones are safe and not safe, or risky or less risky in this day and age. There's a lot of challenges associated with getting the right information to the right people. But from your perspective, what would be the most effective lever to start to move in order to try to better educate and provide consumers in the older adult space with the right information for the right products to potentially have the greatest amount of impact on their health?
Yeah, I think a critical first step is actually talking to them and getting qualitative data from older adults who smoke, as well as including them in research studies. And I do feel strongly that there's a reason there's certain people in life that may continue to use nicotine in whatever form throughout their life. There's reasons for that that are important to them. It's not just that they aren't able to stop, they like nicotine. And so I think better understanding those reasons and, knowledge why there are misconceptions, what leads to that. I think it's very different, say, an older adult that smoked 50 years that thinks nicotine is the most harmful agent versus, an 18-year-old. So I think really age-specific research, and also not, talking over that age group and actually really hearing them.
Yeah, I'm a little concerned as well from one of the data points that you had on your slide around misconceptions on VLNC, very low nicotine cigarettes, as being safer simply because of the lack of nicotine. So I think there's a lot of potential, not to be a doom and gloom type of person, but additional challenges, especially in this particular subset of the population, if policy and legislation goes through in terms of nicotine limits going forward. So the credo has always been, it's the smoke, stupid, right? I mean, if we can make it as simple as that and help clarify the conversation with all age groups, that would be a big win in moving people toward healthier lives.
Yeah, and one quick comment on that. I just
Sure.
submitted a case study to the American Society of Addiction Medicine. I'm not a clinician, but I wrote it with one. And so it's a 55-year-old man. He had a heart attack. He had smoked for 30 years before that. He had tried quitting immediately before the heart attack. And this relates to what we're talking about, because his when he spoke to his I guess surgeon or heart disease specialist, what he heard was nicotine was the problem.
Yeah.
And so when this clinician worked with him, he didn't want to use nicotine replacement therapy. He tried varenicline. There were a lot of side effects, and vaping was totally off the table. And so I think that that's like just an example of some of these critical points of being able to talk to people and educate them, and also what Cheryl was mentioning, a lot of the misconceptions that quote unquote experts have on these harms that are sort of traveling on to people in the hospital or doctor's office.
Absolutely. Excellent.
Yeah,
Thank you.
if I could add something to that, Jeff, I did some qualitative research recently for a PMTA submission to the FDA for a company that makes what people sometimes call a cig-alike product, which a lot of people think are dying out. A lot of companies have stopped making, and this company is actually making batteries and things compatible with those ones that are off the market. And it just by natural evolution, most of their customers are in their 50s, 60s, 70s, and beyond. And it was fascinating to collect information from these folks about why they, their history of smoking, why they liked what they liked. And they wanted something that definitely looked and felt, and felt in their hand everything like a real cigarette, and also to other people. A lot of their peers are still smoking. And interestingly, because this was available in different nicotine strengths, a lot of them were able to wean themselves down even to zero nicotine. And a few said, I realized that my habit was hand to mouth. But and I've heard, I had talked to somebody who was with CASA, the consumer organization for to help encourage smokers to switch to vaping and other products. And her opinion was, being a younger person in her 30s, said, cig-alikes, no one uses those anymore. I mean, I'm paraphrasing here, but no, yeah, they do. And just as Annie is saying, we need research that's really looking at what do these different groups need, and older people are at immediate risk of health harm if we can't get them to switch. So they are a group we absolutely have to be laser focused on.
Yeah, absolutely. One of my early studies, one of the comments from one of the participants was, with a cig-alike, they can hold it in their mouth. They don't have to use their hands. They can actually use it like the cigarette they used previously. And they really enjoyed that aspect of that product. So I think, again, I would imagine the industry would have done quite a bit of work in these spaces to kind of build the right products for the right cohorts. But I think the cig-alike model really does have some opportunity and potential in the older adult space, because it's just something that behaviorally, something that they're comfortable with and have associated with that experience across their entire lifespan. So I think that's a very important factor to include.
I think the research shows, maybe Brad can talk more about this, is that options seem to be critical for people to try different things and find what works for them, whether it's flavors and strengths or device type or product type.
Yeah, and again, I think that ties with one of the questions I had, Brad. I think we spoke a couple of times about the Swedish experience and how that data set is used as an example of where tobacco harm reduction that is, in a sense, engaging all parties, the consumer, the lawmakers, and industry, and have had great results in terms of reducing the use of combustible products over the last several decades. The numbers are really strong, but you might have some thoughts around that space.
Well, there's no question that the use of snus has pushed smoking down, and some of that has been due to smoking cessation, mainly among men. However, snus has had an impact on smoking in Sweden from the get-go. If you look back at lung cancer statistics all the way back to the 1950s, lung cancer was never prominent in Sweden compared to the rest of the European Union and throughout the world. And the reason is that Swedish men never mixed with others in World War I or World War II. Remember, Sweden was neutral in both world wars, so it never had that impetus to start smoking. Sweden has always used snus, and it has impacted tobacco initiation as much as it's impacted smoking cessation. We did a study published on my blog, Raw Dude Tobacco Truth, where we show that snus initiation among kids, boys 15 to 16 years of age, is very common. In other words, they use tobacco like their fathers do, while girls in Sweden use tobacco like their mothers, with higher smoking rates. So snus has also impacted smoking initiation as well as cessation. The package is leading to Sweden having minuscule smoking. And now Norway's followed that. We're seeing some effects in Iceland. And so this is evidence that cannot be ignored.
Yeah, and I agree. And I think it does tie into what Annie is and Cheryl both are saying right now is in the sense that, there's not really one solution to helping smokers transition from a combustible product to a reduced risk products. Again, across the globe, the cultural differences in terms of tobacco use, how the formats, when they start using, the different pressures that drive the behavior are so varied. To kind of think about it from a very sterile tobacco control perspective is really setting everything up for failure in terms of having a positive impact in public health. I have a piece coming out in a couple of days looking at how tobacco control efforts in several Southeast Asia countries, and everything from gender to income to political pressures, all these factors impact the success or lack of success of reducing the harms associated with smoking in those regions. And it can very easily be applied in the United States as well, just because of the diversity of the population, as well as the different time points in your life when one might pick up a cigarette for the first time versus the times that inspire you to look at other options. If other options are available, finding the right one is really key to keep you off and away from combustion and into reduced risk products. We do have a question, and I'm going to try to paraphrase this, and I'll throw it out to the entire panel. But one thing that's often not as well promoted is the benefits of nicotine. And I believe there was a presentation at GNF recently where individuals started to talk about the positive aspects of nicotine from a different perspective. I'm sure everyone's aware of Paul Newhouse's study looking at one of the largest clinical studies that is just finishing up. Data hasn't been published yet, but looking at nicotine as a therapeutic aid to help stave off age-related cognitive decline. And there's been lots of space, lots of work in Alzheimer's and Parkinson's and other neurodegenerative diseases. So I guess I would just, in general, open conversation around we talk about the challenges associated with nicotine, but how do we communicate also the potential benefits of nicotine in a product format that carries little risk along with it? Anyone?
I think it starts with acknowledging reality and looking at subgroups and saying, why is it that so many more people who have schizophrenia or who suffer from depression or ADD or any number of conditions, why are they consistently turning to nicotine more? And and just looking around, being willing to be open-minded and say, what's happening here? How are these people getting some benefits from it? Should we be? Is it ethical to try to take all options away from them? And we just need to know more about it and be willing to look at the data that's right out there in front of our faces. Take our ethical, moral, historical outrage blinkers off.
I'll just add, so a lot of my graduate work was looking at nicotine's effects on cognition. And I was on a meta-analysis with Steve Heichman, helped him conduct it, that found, nicotine separate from, withdrawal and all that does have beneficial effects on some aspects of cognition. A couple of things I've run into, it seems to me there's a history of people talking about benefits or cognition intertwined with tobacco industry, either perceived involvement, whatever's real, I'm not sure. So what I've found as a person that researched that is like needing to walk a tightrope and not, I guess, come across as that, which is, sometimes impossible, like that I'm trying to push benefits and not talk about harms. But I do think that there is strong evidence there, the meta-analysis. I think that there needs to be more controlled research on this. And I would say since I left, so I gave nicotine to Wake Forest freshmen when I was getting my master's, never smokers. I was looking at, the booze, trying to follow up on research from the 80s and 90s, Warburton on, and I didn't find anything in this controlled study. And, it's one study, but one thing that has been published since then is that a person's cognitive functioning at baseline can dictate the benefits of nicotine, at least on cognition. I can't speak to other benefits. And so I think that's really important, talking about things like ADHD or cognitive aging. And so I think that's a really nuanced point that hasn't been looked at a lot. But the other thing I wanted to add is, since I got my PhD in 2007 studying nicotine and cognition, it's really not, it was more popularly researched then. When I wrote a critique of the 2016 Surgeon General's report, I focused on their chapter on cognition and nicotine. It was very flawed. You can read my critique in Nicotine and Tobacco Research. And it was so shocking to me in 2016, I was reading that, which was basically saying nicotine damages the brain. Whereas in 2003 to 2007, when I was an NIH-funded, predoctoral researcher, the theme was nicotine as an enhancer. And so I think that's important to keep in mind as we talk about these effects, the sort of political and social elements around science. And that goes to Brad's, discussion of, the integrity of research and the quality.
Absolutely. Any thoughts on this space, Brad?
No additional comments.
Yeah, to me, the literature from the 70s and 80s performed in the academic space around nicotine's role in enhancing neuroplasticity is really the source of along with the epidemiology of data that has shown these patterns of survivability and reduced risks in these spaces in smokers particularly. I was in the brain injury space, and one of the intriguing questions is that, if you're a smoker and you had severe traumatic brain injury, you're more multiple times more likely to survive than non-smokers. And there's just several pieces of data that exist that we really don't yet understand that connection between the mechanisms and the role of nicotine and the outcomes that are seen. But the opportunity to study that exists, and it was really one of the reasons I transitioned from the work I was doing prior to moving into the harm reduction space. A couple more quick questions. Well, they're not quick, but we'll do our best. Given that we have a lot of information yet to discover about what risks or any risks, lack of risks that exist around ENDS products, and it will take, just like with cigarettes and any products, it will take decades to really start to get kind of the type of epi data you need to really make firm statements of safe, not as safe as we expected, et cetera. What can we do today to best communicate and convince policymakers, regulators, and other members of the community about the benefits associated with tobacco harm reduction?
Jeff, I hear this a lot. Shouldn't we wait? Don't we have enough information? Well, right now we have enough information. 500,000 people are dying from smoking. That's the information we need to remember. And then we look at the chemistry of smoke and vapor. We have a lot of information about that. We don't have almost any information on exactly what vapor is actually causing in vapors. We don't have that. We know what vapor's doing in cell cultures and animal studies where these systems are overwhelmed with all kinds of things. But we don't have any evidence that it's actually harming humans who have switched. And so I don't have a lot of patience with waiting anymore. I think we can act right now to reduce potential risks.
Yeah, but the 500,000 number in the United States is a number that hasn't varied much over the years, even with all the different education, miseducation information that's come out from the regulatory agencies, news, popular press, et cetera. And, that's disheartening. But then if you extrapolate that to the rest of the globe, to 8 million lives lost associated with the use of combustion products, I think the idea of trying to find something that's going to help, that we can show from a chemical perspective, the potential of risk is at least lower, whether it's 20% lower, 50% lower, 95% lower risk. That's probably the more effective way of getting the data, because the lives lost and the numbers associated with that will start to drop.
Yeah, Jeff, if I could say so, I think it's sort of a three-step process. One is making sure people know about, yes, people are still dying because people don't know smokers. People who have health insurance mostly have quit. And so we need to get it on the radar of the physicians and the academics and make sure that they know that's, and then secondly, help them understand the existing medications have not been working, show them now decades of data to show that's, the people who could quit that way have quit, and then find ways to help people feel comfortable recommending alternatives. And I think that's often stories patients need to say to doctors, people need to tell their family members, and so that people can say, well, I don't know, I know we hear a lot about teenagers, but I had this experience. You have to think about, what are they going to say over a beer, over a coffee to their colleague, so that they can feel comfortable, so they won't feel shamed or shunned or, what's wrong with you, if they recommend an alternative product.
And I think, again, part of the challenge in this space is the source of the information. We live in a day where we're bombarded by it, millisecond by millisecond. At any moment, it can be one person's belief or opinion, and constantly bombarded with others that go along with it. So from the consumer perspective, going to sources that have been accepted as at least the purveyors of the most correct information has always been kind of the key way to get the answers that they're seeking. But unfortunately, if we look at CDC and the FDA's websites, they tend not to be very supportive of the harm continuum and tobacco harm reduction principles in general. Any thoughts in that space? Why do you think that the FDA CTP has been relatively anti-tobacco harm reduction approach. And if there is anything that we can do to try to change that.
I'm assuming it's because they, and any individual respond to incentives, and there's so many people ready to slap you down if you try to say, wait a minute, maybe there's some positive situation here, or maybe this is a gray area and not a black and white area. I think another reason is we don't have agreement on what you might call the tobacco endgame. There are a lot of people who still think we are going to eventually wipe out all use of nicotine on the planet or in the US. I have come to believe that that is not realistic. I don't think I always felt this way because I was in an academic cocoon and hadn't frankly thought it through. I didn't know about contraband. I didn't know about all the research that shows what happens when there's still many people, I think, in academia who think if you just pass a policy, it will happen. They don't realize what's coming into, that it's going to all go underground. So that we have to reach agreement on what the end game is. Are we talking about our shared goals to move everybody onto something that's about the risk level of a cheeseburger a day, being using very loosely here, or is it something else?
And what surprises me, Jeff, is how the U.S. approach differs so much from the British approach. And for the Brits, you have the Royal College of Physicians. That isn't a trivial society that has said that vaping is likely to be at least 95% less hazardous than smoking. People don't realize the Royal College was the first organization in the world in the early 60s to come out against smoking. And in fact, it was about 2 years before our Surgeon General published his report that is very well known around the US. So, that's a disconnect that I don't understand. But we need to point out so that people can start to discuss why we're at odds with most of the British with respect to this problem.
I think that's a great point. We need to figure out how to get the good research into the conversation, and bring in data, bring in respect. And an anecdote like that. Did you know they were the first to raise the flag about smoking, and now they have been the first to say, based on the data, this is what we're seeing, because this is what will make academics and physicians and then policymakers comfortable saying, well, I think it's a gray area issue, and I think we have to look at the adults and, hey, did you see this study?
I hear you, but one thing to add where I get discouraged is I cite the Cochrane review that just came out, e-cigarettes relative to other, and working with physicians trying to write ASAM guidance on addressing tobacco and addiction treatment settings, and people overtly discounting that as high quality evidence. And I don't know how to respond with that. At some point, right? It's just, we're not in agreement on what high quality evidence is, but sorry to be a downer on that.
No.
Frustrating.
I think you have to look at your own professional community, whether you're among physicians or academics, or in my case, public health people. I was really surprised when it's been several years ago that I did this data collection on smoking and vaping among people in custody. And I found, just chatting away with people at the Harvard School of Public Health alumni event about the research that I was doing, framing in terms of a vulnerable population, which public health people care about, and opening their eyes to, these are people, they will scrape stuff off the ground to smoke. These are traumatized people with multiple addictions and other kinds of issues. That just reframed the issue for them in a way that really I was pleasantly surprised by, and that allowed them to start, be then a little more open-minded to say, well, show me these data, show me that study. It suddenly was, it was sort of speaking their language, giving them emotional vocabulary and framing and examples that they could work with and they could understand.
Yeah, I completely agree, folks. The idea of whether it's a bottom up or a top down approach, I think is irrelevant at this point. I think we need to communicate quality science whenever we have the chance to. And this forum today was a wonderful example of sharing information with the community in a way that hopefully is both enjoyable and thought provoking, as well as giving them a mission to continue the fight and the movement forward to start to hopefully move the numbers in the right direction, both in this country and across the globe. I want to thank everybody, both online in terms of our audience and our three wonderful panelists. Like I said at the beginning of the session, this will be available online. I will try to get to any of the questions we missed directly afterwards. As well. And I'll either pass them directly from me to the individual that sent a question, or to the individual on the panel that could answer the question most appropriately, but give us a couple of days to get that taken care of. Again, thanks to everyone. And I hope everyone has a wonderful Halloween, and we will see you at our next webinar.